معانا دكتور احمد طه اخر برزنتيشن قبل الصف. دي اهم برزنتيشن اللي اول حاجه هنعملها اول ما تشوف العيان، من اول ما تقابل العيان من غير الاكزامينيشن دايجنوستكس كل اللي قلناه ده هيبقى ايه؟ مش مظبوط. دكتور احمد.
السلام عليكم. First, I'd like for the sake of time, I'd like to highlight certain issues in assessing strabismus case. We will not talk much about the history, but there are certain points to be covered, particularly in low birth weight or incubation and common history of similar conditions. Now for examination, there are certain guidelines to be considered in dealing a child. The first is try to grasp as much data as possible because the child is also, or you only have a glance to get data before getting bored. And then keep smiling because emotions are usually infectious. Toys are very important tools. It's advisable to measure the angle twice for consistency of measurement. Those are the guidelines before trying to assess a child. First, to start with the inspection, certain issues that we covered, which is the lid. The lid and lid pressure position. Is it ptosis or pseudoptosis? Here we can notice that there is an apparent ptosis of the upper lid of the right eye because there is an associating hypertrophy, and in gaining fixation, the ptosis improves because it's not actually a true one, it's a pseudoptosis. And again, if the canthus and the cover gives a pseudo-esotropia and angle cover, we can notice in the right eye that the eye deviates, and including the fixating eye, the right eye did not gain fixation, and gives a photograph showing that the fovea is temporarily dragged. And the head position together with facial asymmetry are very important to notice. This is by inspection. This is the first look at the patient. And then we try to assessment of visual acuity and amblyopia. الكلام كويس، ولكن في الديفلوبمنتال مايلستونز انا بس عاوز اكد على حاجه ان 3 to 5 years the visual acuity is 24 expected visual acuity, and more than 5 years up to date I'm talking about 2030 or 69. So do not expect a child to have the same vision of the other. Sometimes the parents do these mistakes. The child can see what I do see. So do not expect this. Then in preverbal children, the vision of one eye is strongly rejected by the child indicated of a poor vision of the other eye, and the so-called forced choice preferential looking. Usually infants prefer to look at patterns, not than homogeneous. And the so-called famous like Teller acuity card, where there is 2 slides and stripes and a blank one, and there's a hole and the examiner is behind this. You can notice the behavior of the visual behavior of the infant while seeing those patterns. And card is acuity card, the most important outlines must be thick. For those are trying to have an idea about the vision in a very young children or babies. Optokinetic nystagmus or pattern visual evoked potential. I just want to show this to have an idea about how the child, the newborn or the infant or the baby see and how the adults see. So this is the newborn or the baby see the image like this, and the adult see the image like that. In verbal children, 2 to 4 years, we can go for Chi pictures to identify those, or optotypes, either single optotype, but usually this single optotype can underestimate amblyopia, so and linear is better for this crowding phenomenon. A letter E game, it's like telling him that this is not it's like an animal with legs, a table with legs, and to which side it is directed. More than 4 years actually can identify Snellen activity. Sensory anomalies to have a quick view because try to be practical as much as possible. To test for fusion or suppression test, the famous Watford dot test. The patient wears goggles red in front of the right eye and green in front of the left, and the 4 lights are projected for distance and for near. This is what should be seen normally, and this is if we are talking about suppression of the left eye, so you can see only with the red eye, so you see only 2 dots, red, and the other way around, suppression of the right, you can see with the green left eye. Diagonal striated lens could be replaced. There are 2 striated lenses Glasses are, the patient with these glasses with a light projecting in front, and this is the view of the patient. You can see there are two crossing like X, and there's certain explanations if it is an X, the upper to the left, so it is a normal one. If there is not crossing, you are talking about the diplopia or strabismus. If there is suppression, one line of the left eye or the right eye is evident, and crossing to center stone is not that common. Sign up for its device projecting two sides, and the subject should compare. Stereopsis, okay, it's the finest evidence of binocularity. So many famous tests like Diagnostic, where a polarized lens is worn, and the child should comment on whether the wings of the fly are flying or not, or there's an animal coming outside the line. And there is certain trick in assessing to try to over-reveal an stereoblind malingering child is to just switch like 90 degrees. This stereoscopic, the 3D effect is lost. So if the child saying that I can see an animal coming outside of the rose and with 90 degrees tilt of distance, and he is still insisting on that same the same answer, this is not a right answer, and this child is not seeing stereoscopic. Like this, those are the figures, but this is not the way it looks. It looks this. You can only see the star, and there is no polarized lens to be worn. And if the child has no stereoacuity, he can, or depressed stereoacuity, he can just see only the above star. Now to the most important is the ocular motility and motor assessment. I try to focus on this. The pursuit or movement. First are versions. Versions should be diagnosed in the or assessed in the 9 diagnostic positions. There are certain tips to be considered in assessing motility to have a good assessment. First, the target, either specific target or just a pin light torch will be enough. And insist on full gaze. Consider what's full gaze. If I have a virtual imaginary line passing, vertical line passing from the punctum, should imaginary touch the pupil, or the junction between the inner 1/3 and outer 2/3 of the cornea. And the same vertical line passing through the temporal limbs should touch the lateral gans. So if you can notice in here that this vertical line touches more, so there's an excess. And this vertical line here touches this away from the pupil, and so there is a limitation of movement. Again, if you can notice any idea about this, is there any limitation, or is it normal? So you can notice in here, there is no limitation. Again, insist on ipsilateral fixation. It's very important, by putting the thumb or the occluder on the root of the nose. This is a very trick that make sure any deviation will reveal in the side gaze. On the ipsilateral eye of assessment, you can notice any limitation or excess. And again, like here, if you can notice, there is a limited abduction of the right arm. There is of the left arm. Okay? And if there is any associated nystagmus, like a tax one in case 5. And the contralateral eye have an idea about the vertical deviation, the up or down shoot, or that fissure, if there is a twinge or something. Try on examining to touch the eyebrow first when raising eyelids. Usually with the stress or the examination that you might raise the eyelid in person. And now you touch the patient's eye, the globe, which is very hard, and we should not harm the patient. And again, you should not cross the visual field of the patient. So try to switch hands with the target, not with the same hand, the same positions. There is a simple video showing how to test for versions. Again, the thumb on the root of the nose, and look at the full gaze, and go up, and asking permission, raising both eyelids. And even if this looks harsh, it's not harmful to the patient because I'm not touching the globe. And then switch hands, and then again the thumb on the root of the nose, till the end of the gaze, then going up, then again asking permission to raise the eyelid and go down, and then to the middle, just up, and with permission, raising the eyelid, looking down. For ductions, usually done either if there is any limitation in versions, or we can ask it just do duction. Again, it's very important to full gaze in the direction of action of the lead or any limitation of the version. Again, do not touch the eyelid directly, not harm the patient. And there is a really short if you are going to do it without any limitation, just doing duction. Again, slow to the full of gaze, and then asking permission, raising the eyelid, going down, and going to the outside, up, and with permission of the patient, to raise the eyelid. Do not touch the patient unless taking permission. And that's it. So, if there is any limitation of duction, what would we expect? We expect the so-called incompetency or incompetence strabismus. So what to do in this? Either to test for saccade, part Stereopsis, if there's any, the famous part, Stereopsis 3-step test in case of vertical deviation, force reduction test, active force generation test, and you might ask for Hess stream test. So, in the saccade, could be horizontal or vertical. It's very important the targets to be at the ends of the gaze. We want to full gaze, full range of movement to test any incompetence, either restrictive or operative. From the midline action, relaxation of the muscle from the gaze to the midline. When you test the effect of the muscle from the midline to the direction of action of the muscle to be tested. Could be restrictive or operative. And there is a video showing how to test for saccade. Again, there are two targets displaced aside, and the patient is asked to look quickly between them. We have found here there is no limitation, there is no abnormality in the horizontal saccade. Again, the same in vertical saccade, the two targets are displaced upside, up and down, and patients are asked to look in both directions. Again, there is free, there is no limitation. Force reduction test with topical anesthesia. You can grasp with a tooth at the limbal conjunctiva, stretching. Now we are examining if there is any tightness of the medial rings. We resist passive abduction. Active force generation, again with topical anesthesia with a Q-tip and stretch the eye or doing passive abduction. Now again we are testing the medial rings. And you can feel, asking the patient to look to the left. You can feel there's any resistance underneath this cotton tip is indicating that this muscle is not a dead muscle. Screen test, one of the dissociated tests, dissociate the patient with both eyes, and patient will have a red-green goggles, red in front of the right and the left, a green in front of the left, carrying a green pointer with red lamps are illuminated. This is a small diagram showing that there is a limitation in abduction of the lateral rectus with a pseudo overaction of its yoke. Again, this is the real printout showing that the lateral rectus here, the curve is limited, and here the curve is extended. We test for versions, conversions, and diversions. In nystagmus, it's a bit complicated, but at least do certain issues like direction of nystagmus, the waveform, is bender or jerky, the amplitude, and the resting position is very, very important. Because the resting position indicates the flow zone and might be responsible for anomalous position. Of course, frequency is to be recorded. Deviation, how to measure deviation? Again, it's very important is to assess deviation through either corneal light reflex or corneal reflection test. Corneal reflection test, like Hirschberg test, with its rules, if the corneal light reflex is on the pupillar border, we are talking about 15 degrees, and less than 45 degrees. And Bruckner test is very important because it can combine examination of the red reflex and the corneal light reflex. Sometimes we can see in here that the pupil is red, and there's a red reflex, and the corneal reflection touches the outer edge. Creamsy test, the prism is placed over the deviating eye, over the fixating eye, with the apex towards deviation until the reflex is centralized in the deviating eye. It measures only tropia. The golden standard assessment is the cover test. And cover test is very important to assess or ascertain something. The patient must be examined that he can see the target by either eye. And there is no point to do cover test in a patient with a non-seeing eye. It's a fatal mistake. So we can test it for distance and near with and without correction. Certain types like cover and cover test, alternate cover test, and prism alternate cover test for measurement of the angle. Can please, you can see in this video that we cover the left eye. There is an inward deviation of the right, so on the right is it. Why is saying right? Because covering the right eye, there is no movement of the left eye. So we can say that there is a unilateral or fixation preference if you can test. And then alternate cover, it's like 1, 2, 3 seconds. But the most important in the alternate cover is to wait until it gains fixation. And this is with the prism. To measure the real angle again, the patient is looking at the target. There is no cover test without a target. There is a certain video showing that you should wait until gaining fixation. If you wait very quick, you will miss the real angle. You can see the right eye is amblyoptic and deviated. And by covering the left eye, if you did it in a very quick way, the patient did not fixate. She did not fixate with the right eye. So this is an underestimation of the angle. You should wait until the deviating eye gains fixation. Then we wait and wait until it gains fixation. Then we can measure the real angle. Wait and instruct to look at the target until gaining fixation with the weak eye. Maddox rod and wing for heterotoria, distance and yield. The part Stereopsis is one of the most difficult ones for assessing vertical. I will not discuss in details parts Stereopsis, but just an idea. We do have a right over left or a right hypertrophy. We can note in here, if the hypertrophy is in the ipsilateral gaze, just please pay attention that it's an inferior problem. Parts we are talking about, we are searching about the weak muscle, the paretic muscle. So try to make it a bit easier. If the hypertrophy or hyperventilation increases on the ipsilateral gaze, usually the problem is an inferior, either inferior rectus or inferior peak. And if the hypertrophy became worse or increased on the ipsilateral head, usually we think of peak. So if this might help, if there's ipsilateral improvement thinking, ipsilateral increase in hypertrophy, think inferior, either ipsilateral or contralateral. There's ipsilateral improvement, increase in hypertrophy, think of peak. So any idea about this? There is a left over right, or left hypertrophy. This hypertrophy increased in which case? The ipsilateral or the contralateral? Again, don't be biased. Don't be biased. This is the hypertrophy, and this is the contralateral gaze. Again, here or there. So it increased in the contralateral gaze. So to start by exclusion, it's not inferior. Either inferior rectus or inferior peak. And so it's either superior rectus or superior peak. The weak muscle is not inferior because hypertrophy increased in contralateral, not ipsilateral. Again, we are forced to choose between two muscles, either the superior oblique or the superior rectus. So head test, the hypertrophy increased in ipsilateral head. So it is not superior rectus and it is superior oblique. Here in this test, we go by exclusion. By exclusion, which the weak muscle is. And you should try when assessing the hyperdeviation, usually the axis of the prism should be parallel to the eyelid. If you're going to tilt, you should tilt the prism here. And then anterior segment examination in the state lamp, either stable or portable according to the age, posterior segment entirely, and there's a bit a sort impact of fundus when examine the fundus besides the ordinary examination. As strabismologists, we should have an idea about the torsion. So if this is the view seen by the doctor with the impact of thermoscope, and the fovea is a bit higher than the center of the optic disc, we are talking about exposure. And here if it's looking down, we are talking about involution. Very important to us as strabismologists as an extra information. And by the way, if you have a fundus photography, the other way around, because the image is not inverted. Debate about sedation, either with chloral hydrate with such a dose, 50 milligram per kg, could be raised at double. It's a short acting, could be given oral or suppository. Chloral hydrate is the safest sedation. Can be given up to 3 gram total dose on 2 doses. There is a propofol and DPT. The debate is, please do not compromise the consciousness status of a child, particular child in the clinic. I've been, like, I won't say malpractice, I would go, it's a sort of trial, that you give the child sedation without the presence of a well-trained personnel with ventilator support. This child can aspirate, that's simple, despite even fasting if the mother is dying. Or there is an associating neurological disorder causing a bit of respiratory suppression, which is unexplained, unpredictable. So we don't have that. So sedation, try to avoid. زي ما دكتور ايمن قال ان احنا ممكن تحاول تفحص العيان، خلي السيديشن والانستيزيا في الاخر خالص. Okay. Thank you.